Welcome to AIM Rapid 2024. Today, we are going to discuss the topic bone blast. In this module, we are going to discuss the pathophysiology, the clinical features, diagnosis and treatment. An explosion is defined as an instantaneous transformation of a solid or liquid component into gaseous form and thus releasing tremendous amount of kinetic and heat energy. There are basically four types of blast effect: the primary injury, the secondary injury, the tertiary and quaternary injury. The primary injury is caused by the direct effect of the blast wave over the pressure on tissues by the following mechanisms like spalling, shearing and impulsion. Spalling is defined as the displacement and fragmentation of a dense medium into a less dense medium, whereas shearing or inertia is defined as the stress caused by the blast wave that is traveling through different tissue densities at different velocities. And impulsion is a less dense material that is displaced into a denser material. Secondary injuries are the collateral damages from flying objects and shrapnels. Tertiary injuries is the victim being propelled through the air and striking stationary objects. Quaternary injuries refers to the burns, smoke inhalation and chemical agent release that is produced during blast injuries. Coming to the factors that are affecting the blast injuries. The most common factors are the distance of the victim from the site of explosion, the surrounding the enclosed or open space, the surrounding environment, the quantity of explosives and the type of explosives, and finally the embedded shrapnels. Coming to the clinical features of blast injuries. Most common type of injuries occur in bombing events. There can be injuries which include, in primary blast injuries are the pulmonary, auditory and abdominal compartments. There can be serious penetrating injuries, solid abdominal organ injuries and even intracranial injuries. Coming to the cardiopulmonary system, pulmonary barotrauma is the most common fatal primary blast injury. It occurs due to the pressure differential across the alveolar capillary interface that causes disruption, hemorrhage, pulmonary contusion, pneumo or hemothorax. The other cardiopulmonary complications are air embolism and pulmonary fat embolism. Coming to issues that is related to the ear, there can be tympanic membrane rupture and even dislodgement of the ossicles. In the abdomen, the terminal ileum and cecum are the most common injured areas. Coming to the brain injuries, there can be the penetrating shrapnels, which are the most common cause of brain injury. There can also be a component of blast over the pressure induced compromise of the blood-brain barrier and cerebral blood vessels. The other symptoms that can be seen in blast injuries are headache, seizures, disorientation and even weakness and numbness. The vascular injuries that can be seen are the small entry wounds from shrapnels that leads to initially the vascular injuries and then associated compartment syndrome. There can be external hemorrhages. In ocular injuries, it ranges from the lid lacerations, globe ruptures, the dislocation of the lens, vitreous hemorrhage and retinal tears. Now we come to the criteria for triaging. Blast injuries, in the ED setup we will triage severely injured patients and lightly injured patients. Any of the following criteria, if one is met, that comes under severely injured patients. There are any signs of airway compromise, breathing difficulty, hemodynamic instability, altered level of consciousness, vascular trauma and extensive second or third degree burns, which means A, B, C, D, any of these is met, then any of these is compromised, then the patient comes under severely injured category. Whereas for lightly injured patients, the criteria are minor wounds, first or second degree burns, anxiety states, and mostly walking patients and isolated trauma to the limb. Coming to the treatment, we have to follow the primary and secondary surveys. IV fluids to be given as initial line of management if there is hypotension, and we need to think about arranging and transfusing blood products in appropriate situations. Application of tourniquets and tranexamic acid in the case of uncontrolled bleeding. Copious irrigation and disinfection of the wounds are necessary. Temporary splinting and tractions are needed in musculoskeletal injuries. Also, prophylactic antibiotics needed to be considered. Another mainstay which has to be done in the case of treatment is pain management. If there is hypotension, we need to start the patient on IV fluids, and depend on the conditions, we need to think about continuing the fluids or to transfuse the patient with blood products. In the case of liver failure, we need to start the patient on hydration, IV fluids, and other supportive measures, and dialysis if needed. There can be metabolic abnormalities like hyperkalemia, hypocalcemia, and the corresponding treatment to be given. In the case of cardiac arrhythmias, we need to monitor the cardiac status of the patient and look for any abnormalities, especially electrolyte abnormalities. There can be secondary complications, so we need to monitor the patients for compartment syndromes. For treating open wounds with antibiotics and tetanus toxoid and debridement of the necrotic tissue to be done. We can apply ice to the injured areas and monitor the 5 P's like pain, pallor, paresthesia, pain with passive movement, and pulselessness to look for features of compartment syndrome. We need to observe all crush injuries with caution, even though the patient looks well. Delays in hydration more than 12 hours may increase the incidence of renal failure. Coming to the symptoms that are seen in blast lung injuries, there can be tachypnea, hypoxia, cyanosis, wheezing, hemoptysis, curved chest pain, and finally hemodynamic instability. Coming to the management, we have the mainstays are oxygenation, close observation, fluid administration, and watch for air embolism. First is oxygenation. High flow oxygen sufficient to prevent hypoxemia via non-rebreathable mask, CPAP, or endotracheal intubation if necessary. If there is a case of hemothorax or pneumothorax, we need to consider ICD. Close observation should be done to look for tension pneumothorax and other complications. Fluid administration should be done to meet the tissue perfusion, but we should avoid volume overload status in the patient. We need to watch for air embolism. Place the patient in prone position, semi-left lateral or left lateral positions, and transport to a facility with hyperbaric chamber if you are suspecting one. So, in this module, we have discussed blast injuries, the pathophysiologies, the various types of blast injuries, the criteria to triage patients into severely and lightly injured, and finally the complications and treatment of blast injuries. Thank you.